All right. Good evening, everyone. My name is Marisa Pontillo. I'm here on behalf of the American Academy of Sports Physical Therapy Rise Committee. We are very excited to be doing our third webinar. Um, and I will hand it over to our collaborators, PT Proud. The only other thing I want to mention is that if you have anyone this is being recorded, if you have anyone who is interested, we will be posting it open access, just like this webinar. So you'll be able to access the materials. Um, and that if anyone's coming to CSM, the AASPT Rise Committee is holding a social event. It's Friday. I know it's Friday. It's called the ASPT Rise Social, and we have an icebreaker and a bar and prizes. So open to everyone as well. So it's a good time. But um, Keelan, thank you in advance. And Michelle, I'll hand it over to you.
Thank you so much. And thank you all for being here and allowing us all to put this on for you. And hopefully, we all learn a lot. I am the programming lead from the PT Proud SIG under Ally. I'm super excited that we get to help put this on with the Sports PT Academy. And I hope everybody is excited to learn from Keelan. And we too will be at CSM. So please stop by if you're not familiar with PT Proud. That's part of us doing this and collaborating together is to show that we hope to do more in the future. So please stop by if you're going. And otherwise, I want to give the floor to Keelan Godzi and take it away.
Hi, my name is Keelan Godzi. I go by they, he pronouns. I am currently at Johns Hopkins Hospital. I'm the coordinator of their sports physical therapy residency. I am also one of the primary therapists for Johns Hopkins University Athletics. And I really appreciate y'all coming to listen to me jabber about physical therapy for the transgender, gender diverse, and non-binary patient. A little bit more about me, just so you can understand like why I'm giving this presentation is I was the first transgender athlete to come out in the NCAA in God, I think it was like 2005. I have competed as a transgender athlete. I have worked as a transgender physical therapist as a very out and open person. I've competed for the U.S. national team for the Pan American Games as as an out transgender athlete as well. So sports and transgender healthcare is something I'm very passionate about. So thank you again for your time and coming and for doing this after a work day. So thank you. So some of our objectives are just we're going to learn a lot about terminology. We're going to learn about some demographics and also systemic barriers and socioeconomic barriers, best practices, and some of the musculoskeletal implications for gender non medical gender affirming care, which we will learn about. Just as I meant to tell you, I am on the end of like a head cold, so if my voice is kind of weird or like I start coughing, I do apologize. It's that time of year. So I always start this conversation with this quote. It is revolutionary for any trans person to choose to be seen and visible in a world that tells us that we should not exist. This was said by Laverne Cox, who is a transgender activist and actress. I think this is especially true right now and has always been true, and something I think she said it perfectly. So we're going to start with terminology. This is really the most important aspect of our care. This is how we talk to people. This is how we build a rapport. This is how we get to show our patients that we are listening, we hear them, and we are trying to understand them. But language is complicated. It evolves and it changes rapidly, and it can often feel really difficult to keep up with language. Like a great example is like a lot of terms have changed over the years from like even in the last 5 years, some of the terminology has changed. And so I give this or a talk similar to this probably like about 2 to 3 times a year, and I still update the terminology. I have to make sure I'm using up to date, especially with like newer generations like Generation Z and like Alpha and all that. And so just know mistakes will occur. Apologize and learn, correct, and make a conscious effort to learn the most appropriate terminology. Everything I'm going to be talking about moving forward is very specific to North American English. So if you're working with people who are from other countries using other languages, religions, cultures, it's really important to familiarize yourself with the terminology specific to the populations you're working with. Like a good example of that is in some Native American and indigenous groups, like two-spirit is used as part of to describe a transgender person or a non-binary person. And so you just need to learn the terminology that's specific for the groups of people that you are working with, because it may be different from what I am listing today. So we're gonna start with the kind of just the very basic stuff of like, so sex assigned at birth. This is just something a doctor assigns to the child based off of the external genitalia. Gender is a social construct used to classify a person as a man, woman, or non-binary. This is not the same as sex assigned at birth. This is more of a social constructed view. And then intersex is a group of congenital conditions where the reproductive, sexual anatomy, and or sex traits differ from traditional definition of male or female. The thing that's really important to note about this is people who have intersex conditions don't always show up at birth, and sometimes these variations can show up in puberty and in adulthood, or and may not even be known until postmortem. Like a great example of this is the 800-meter Caster Semenya, who didn't know that she had an intersex condition until she was tested by the International Olympic Committee, and like she just really didn't know. And that's a good example of that. The other thing to know is people who have intersex conditions can have any gender identity and any sexual orientation. What's also important to know is if they were diagnosed from a young age, sometimes or oftentimes they may have already gone through some sort of medical treatment to address the physical and or hormonal differences in order to better align them with the sex that the doctor feels would be most appropriate based off of that person's current anatomy and chromosomal and sex traits. Okay. Gender identity, that's kind of like a big part of what we're talking about today is the internal sense of self and how someone fits into this world from the perspective of gender. This is not rigid. This can evolve throughout the life cycle. For some people, it is rigid. For some people, it's not. And it really evolves if they evolve as humans. Sometimes it's a little more fluid and then becomes rigid. It's just this is not a rigid thing. Gender expression is how we display that gender, though, but this is based off of cultural and social constructs of what masculine and feminine expressions of gender is. But this is how we kind of express our gender identity to the outside world. And then sexual orientation is a multidimensional, immutable, emotional, romantic, and or sexual attraction to people. This is independent of a person's gender identity. I'm gonna share this. I love this picture. It's the gender unicorn. I think it's a really good visual representation of everything I just talked about. Um, I I think it really easily kind of explains it all. So gender binary. It's man, woman, masculine, female, or masculine, feminine, male, female. Um, it's saying that gender is only between those two things. All right. So transgender. So I want to also make note, I have in the parentheses like abbreviations. That's because I'm going to be using those abbreviations a lot moving forward. So just so you know, okay? Transgender. So this is an umbrella term that describes a person whose gender identity differs from their sex assigned at birth. Typically, not always, but typically, a person who identifies as transgender still follows a gender binary, meaning like a person who was born female, assigned female at birth, may identifies as a man or trans man, and so it still follows that gender binary. Gender diverse and gender expansive. These are umbrella terms for people whose gender identity falls outside the traditional ideas of male and female. This is oftentimes more complex, fluid, and multifaceted. And then non-binary. This is an umbrella term for people whose gender identities fall outside or go beyond the gender binary. And so this is where it can get a little overwhelming sometimes and a little it can be to as far as like gender diverse, gender expansive, and non-binary, because often you might hear all of three of those terms used interchangeably. That is not usually okay most of the time because there are different things for different people and also different cultures and different generations, everything. Oftentimes, again, these are not rigid rules, but oftentimes gender diverse and gender expansive is still following that gender binary, but that person's identity is very fluid within the binary. And non-binary is more that person does not identify as either within, or it does not identify as within the binary at all. Not every person who identifies as non-binary identifies as transgender. That's actually really important to know. And it's also important to know that like sometimes like terms like gender diverse and gender queer or gender expansive are sometimes people who are still kind of exploring their gender expression and identity and maybe have not are still like not like they're just exploring and living within all the possibilities, which is an awesome and cool thing. Um, like a good example of this is like, so I'm gonna use myself as an example a lot because it's who I got. So sorry. I identify as a trans masculine non-binary person. So I always have as identified as trans, and I think part of it is generational. Like when I came out, that was really the only term I had for myself. It was really like not super common to meet trans like non-binary people, and it just wasn't something I was exposed to. So I think it was something that like as I was like evolving in my life, I was like, oh yeah, like that's actually more me. I'm not actually like I don't really see myself as like a guy, more like in that trans masculine non-binary. And that's what I mean by it being fluid too. Sometimes it's like like we don't have the language sometimes because of how we like lived and like whatnot. But it is really important because these terms can be used interchangeably that you use the identity that the person you're treating uses or your friend uses or whatever. And then cisgender is a person's gender identity matches the sex assigned at birth. AFAB and AMAB are just really quickly like assigned male or assigned female at birth, okay? So, chosen affirmed name versus dead name. So, dead name is typically the name that was given at birth. That person no longer uses this name and it should not be used. Whereas, chosen name is, or affirmed name is the name that the person now goes by. The thing is, this may be different than their legal name because there's a lot of barriers for being able to change your name legally. Everything from being able to have the appropriate documents, time to go to the courthouse, money. And every state's different in how easy or hard it is. And so most electronic medical records have the ability to have both names very visible on the chart. And it's very possible to have, and it's also perfectly okay to only use the person's um chosen name when documenting, and you do not need to use their legal name with the exception of like where like the medical record number needs to be. There are certain spots that the legal name has to be. Otherwise, you can write Keelan. If my legal name wasn't Keelan, you could write Keelan presents with blah 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 blah, right? And then pronouns, it's how we refer to people. I'm gonna just, this is not, I just want to be very clear. This is very much not an all-encompassing list. There are many versions of pronouns out there. I'm just gonna take note of a couple of them so you just know either how to say them or what they mean. So Zzier, you might see that for someone who identifies as non-binary or gender expansive or gender diverse. He, they, or they, she. So I use he, they. Um, they can be used interchangeably. So like the way I prefer to do it is professionally. I always use he because I do not want my gender identity to be a source of conversation with my patients. And I know unless like I am actually working with a person who is trans or non-binary or gender diverse, I have found it to be sometimes detrimental to my practice. But I do prefer they. But if you meet someone that uses both, what I usually do is I ask them, which one would you prefer me to document with? and I use whatever that person then chooses. And then MX is just pronounced mix, and it's a non-gendered way of saying Mr., Miss, or Mrs. And I really love that. So, gender dysphoria is clinically significant distress caused when a person's sex assigned at birth doesn't match their gender identity. This is really important because this is an ICD-10 code. It's also in the DSM-5, but it's important because in order to attain any gender-affirming medical care, such as hormones or surgery, you must have this diagnosis, and you often have to have this diagnosis depending on the procedure, the medical care you're trying to attain. You might need to have multiple providers indicate you have this. So multiple psychiatrists, multiple psycholog and or psychologists. It is required for oftentimes as like a way to get into the clinics, but also in order for insurance to pay for it. It's just not going to happen unless you have it. Um, but also not everybody has gender dysphoria the same way. So some people have it as a general dysphoric feeling about like their entire being. Some people have it about certain aspects about themselves. And this is also a fluid thing too. So like you might, as a person is going through either social, medical, transitioning, they might have different levels or layers or feelings around dysphoria, and they evolve based off of how they're presenting in this world, and the world is seeing them. Okay. um Gender affirming care is just like it's a broad-based approach to healthcare that recognizes and respects a person's gender identity. So like everyone who's like here tonight is trying to practice gender affirming care, whether you're actually treating like someone post-operatively or post hormones or something. It's just by wanting to provide this inclusive level of care, it's providing gender affirming care. Okay. um Social transition is not limited to, but it includes changing your appearance and pronouns under name. Legal is changing your name and legal sex on government issued identity documents. This, again, is not something that's always feasible for every person. Maybe they don't want to, maybe they can't because of financial reasons. A lot of times people become unhoused. They are taken out, they are kicked out of their homes, and so they might not actually have their legal documents to be able to change. And it can be hard for them to attain. There's so many reasons. And then medical transition is we typically think of this as gender affirming surgeries and hormone therapy. It is not, I say this as a caveat, and I think we've moved past this since when I first came out, but it is not required to have medically transitioned in any way, shape, or form to identify as transgender, non-binary, or gender diverse. It is not required. This is a personal choice, and everyone chooses what their path is. All right. So I always like to talk about coming out because I think everyone thinks it's like, I don't know, it's like some like Hollywood event and you sit everyone down and it's like you have an uncomfortable conversation with people. And you do. And you sometimes do. But a lot of times it's very different. It's done all the time. Person who is not cisgendered and not heterosexual is coming out in a very complicated process all the time. There is no right way of doing it. Oftentimes, especially for trans and gender diverse, non-binary people, we are coming out to different people at multiple stages of our lives for different reasons, or we're choosing not to for different reasons. Oftentimes, if you get new medical providers, you are having to come out to each one of those medical providers, or you are outed because of your medical chart and all these things. And oftentimes this can come with like really invasive, and I'm going to talk more about this, but invasive questions about genitalia and procedures that have been done. Coming out is one of the most life-saving things someone can do. It's such an affirming process of being able to live authentically and outwardly as who you are with the people around you. But it can also be incredibly dangerous. More than 16% of transgender and non-binary youth have had to sleep away from their homes and their family and their caregivers because of because they were kicked out of their house, and over 55% have had to do so because of mistreatment, have experienced mistreatment or have fear of mistreatment at home. So it can be very dangerous as well. And it's just important to know that just because a person comes out to you does not mean they're out to everyone. So it's really not our place to out someone. So we're going to talk a little bit about demographics. So in the US, only 1.1% of adults identify as transgender. That's just 3 million people. Of the LGBTQ population, 1.2 million identify as non-binary, and less than half of those people identify as transgender. There is a rising prevalence in younger populations. It went from 0.9% to 1.8% identify as transgender. A lot of this was thought because of just at the time there was greater safety in coming out, there was more acceptance, and things like that. This was as of 2019. I don't have newer data as of right now. Um, We're going to talk a little bit. So, moving forward, we're going to be talking about social determinants of health for a little bit. And it's really, really important. And this includes economics, stability, food, medical care access, education access, neighborhood that we live in, grocery stores we have access to, like, et cetera, et cetera, et cetera. This is important because of the term of intersectionality, which is a concept of a person's various identities, especially when their marginalized identities are interconnected and cannot be understood in isolation. It helps with the understanding that of the multidimensionality of healthcare in marginalized communities. If you want to know more about this, Dr. Kimberly Crenshaw has this is her concept. Like she has talked about it and written about it. She has a TED Talk. It's wonderful. Um, a great example of this is if we talk about Black trans women, they are dealing with the racism of being Black, and then the marginalization of being a trans and being a woman. And so we see incredibly high rates of HIV, cardiovascular disease, diabetes, violence, rape, sexual assault, and murder in that population compared to other populations. And it's entirely related to the intersectionality of their multiple marginalized identities. Okay. Um, Moving forward, most of this data is coming from the largest transgender health surveys in the United States that have been completed in 2015 and 2022, as well as through the Williams Institute of the UCLA, who does wonderful work. But they do not differentiate between non-binary and transgender. So everything is listed as transgender, and I just want to be very clear about that. So if I say non-binary, then it was differentiated. Otherwise, it was not. Okay. All right. So 1 in 3 transgender adults report an annual household income of $25,000 a year. That is not a lot of money. So when I talk about the cost of medical care, I'm talking about the cost of like changing your documents. And if you're making below $25,000 a year, that is not always a feasible thing. 4 and 5 were reporting discrimination that affected their ability to get hired. 1 in 3 adults have experienced homelessness in their life. And transgender people are 4 times more likely than cisgendered people to experience violence. These rates go up dramatically when we're talking about Black, Middle Eastern, or American Indian populations. The violence included rape, sexual assault, aggravated, and simple assault. More than half of transgender people report poor physical health for at least 1 day a month. This is 18% higher than the cisgender population. Greater than 50% of transgender people avoid medical care because of the cost. There is an increased likelihood of developing cardiovascular disease and having asthma. There is 2 times more likely to have chronic depression. 81% of transgender people versus 30% of cisgender people have contemplated suicide in their lifetime. 42% versus 8% have attempted. As of 2020, 1 in 2 transgender people had insurers deny coverage for gender affirming care. 78% of the people who responded to the US Transgender survey wanted hormone therapy at some point in their life. Only 49% have received it. And of the people who wanted some form of gender affirming surgery, only 25% have been able to access it. This is due to multiple factors. This is cost. This is access to a provider that can do it because this is actually even more relevant now where the doctors like the wait lists are getting to be astronomical. The access to medical care is getting harder and harder and harder to get, and people are now having to travel even further than they used to. And then we're dealing with cost, insurance denying it, etc. Okay. About 50% of transgender people and 68% of transgender people of color has reported medical or mistreatment by a medical provider. This includes refusal of care, verbal abuse, physical abuse, sexual abuse, misnaming, mispronouncing, mocking, you name it. And more than about a third of transgender people will either postpone or refuse to access medical care due to either a previous history of mistreatment or fear of mistreatment. I I like to use myself example here because I think sometimes we see the numbers and we're like, oh, that doesn't really happen. I've been a physical therapist for 15 years. I've and even in my own and I'm not and so when I talk about this, nothing I'm talking about is where I am currently working. I'm actually working at one of the honestly, I will say this, and I'm not saying this because I work there now. I'm actually saying I have never worked at a clinic or a hospital that is as affirming as Johns Hopkins is. So I just want to make that clear. But like I have been denied care. I have been denied access to care. I have been mocked. I have had my body shamed by medical providers, including physical therapists. So these are real things that do happen. About one third of transgender adults report having to teach their doctor about being transgender just to receive adequate care, and that's just adequate. Okay. A lot of times this is because medical schools just are not providing the education that they need to in order to best serve this population. You have more than 50% of medical schools do not educate on LGBTQ population beyond HIV. So doctors are not being set up for success. So like the people who are like working in the trans health clinics, they have spent the time, they have put in the effort to learn in and to understand our population. And I think in that is and because the medical schools are not teaching it as well right now. And oftentimes transgender adults are often asked very, very invasive questions about their genitalia and surgeries and then opinions based off of that. So it can be very distressing for a trans person to go to the doctor, often leading to greater illness due to not getting basic care. This is a good graphic of explaining the amount of abuse that people can have. So, sports. Not a lot of data on this. Honestly, like truly, like I've been looking for a long time. Not a lot of data. It's actually really poor statistical data on the number of athletes who identify as transgender. The Williams Institute and the HRC have kind of estimated the numbers that I'm giving you. They made it very clear these are very gross estimates and they're so I please do not take everything I'm saying here as like this is set in stone. Like they were even very much like these are very gross estimates of about 40% of 13 to 17-year-old transgender youth play on one sports team, and then 52% of transgender youth under the age of 12 play on one sports team. I think what is really important to note is that as of right now, like as of today, there are 10 out transgender athletes in the NCAA. There is 500,000 athletes in the NCAA. So that is 0.002%. There are more bans on, there are oftentimes more bans on participation in sports than there are transgender participants in sports. Okay. 27 states have banned or greatly restricted the participation of transgender youth in sports. And I want to be very clear, these bans are entirely focused on the participation of transgender women. Everything about these bans have actually fully erased transgender men, and it's only on the participation of transgender women. The IOC and the NCAA, as of this year, have also greatly changed their rules to limit the participation of transgender women as well. As of 2025, there were 876 legislative bills that were introduced in 49 states. They include removing protections of discrimination and preventing the recognition of name, pronouns, and gender identity at schools, prohibiting the healthcare of minors and adults and or preventing insurances from providing coverage, Medicare, Medicaid, restricting safe access to public facilities, and also restricting the ability to put on events that are deemed gender nonconforming. So what that means is like drag story hour or something like that. Another thing I'd like to take note is 1 in 6 hospital beds in the United States are Catholic hospitals, which do practice under transgender exclusive ethical and religious directives, meaning they can deny care to anyone who enters their door that is transgender based off of religious exemptions. And the reason why this is important is when we're talking about people in rural communities and they don't have a lot of, they're not in like Baltimore where I have like 5 hospitals I can go to if something were to happen. If you're in a rural community, you only have that one hospital, and maybe that hospital practices transgender exclusive policies. Like you're going to be in a really tough place if something happens, and and again, it's a further restriction to equal health care. These are states that are have bans on gender affirming care. So, transgender and gender diverse people have gone through just a plethora of medical mistreatment. So, it's really important that we are, as providers, practicing trauma-informed care. And this isn't just for our transgender patients, this is for all of our patients. It's really important that we provide a place that ensures physical and emotional safety by avoiding unintentional re-traumatization through verbal, nonverbal, and visual indicators of inclusivity and safety. Physical therapy is incredibly hands-on. This can be very triggering. I'm a fellowship manually trained therapist. Like I use manual therapy like a lot. So we must inform our patients when a hands-on approach is necessary. The part of I think that we forget with trauma-informed care is it's not just about telling the patient what we're doing, it's actually giving that patient the autonomy to say no. You have allowed them, you have said, I think this is going to be the best approach. Are you okay with that? They should feel comfortable and safe to say, no, thank you. Um, because that will provide a level of trust that, like, maybe it's no today, but maybe in 2 days, or maybe in 3 visits, or in 4 weeks, it's a yes. To build that trust. Also, when we're doing manual therapy, just because, and this is part of this trauma-informed care, and especially with like when you're dealing with people who've been through any sort of that might have any chronic PTSD, sexual trauma, transgender, non-binary people who are dealing like have a lot of sensitivity around their body and touch. We need to consider that just because they gave consent to touching or one manual therapy technique does not mean that they've actually consented to a blanket of manual therapy techniques. So it is also then making sure that we're constantly checking in and getting that consent as we go. And then also really making sure that when we're talking about gender anatomy, we're asking what each person wants to use for their terminology. So we're not just using um, breasts for a transmasculine person that maybe doesn't want to talk about their breasts. We need to also then explain, one, we need to ask them how they want to refer to that part of their body. And then two, why are we talking about that? Because we need to relate it back to their care. So for best practices, we want to make sure our forms allow the patient to indicate their gender, pronouns, and chosen name. And again, most electronic medical records do allow for this. The one thing to take note, and I actually know this just because I've worked at a couple of different major hospitals, and this has actually come up at each of them, and it's just like a weird thing in the system is some EMRs, I see the person's chosen name and correct pronouns, but the front office sees their legal name and legal pronouns, and that's it. And they have no idea that it's different. And so now we're having a situation where this person has been dead named and mispronounced right as soon as they enter the door. And it's not actually because the front office was trying to be rude or malicious or anything. They actually just didn't know. So it's really important to make sure that every part of the person touching that chart sees the same things because sometimes what the front office sees versus what the clinician sees are different. We need to have safe bathroom and or changing spaces. I understand when you work in a hospital or a small clinic, there's not always a lot of room with that where you can just have a single stall, but you need to make sure that like either you're able to say like I don't know, like make it so like they're the only person in that room potentially when they're there, or that you have at least one space where that person can either change or use the bathroom. If you have, this is my one, this is a soapbox, I shouldn't say my one. If you have men's rooms with like stalls where like the toilet is, please have a small trash can or some way to dispose of menstrual products. This is a very small thing that makes a very big difference in the safety and mental health of that person, okay? Try to avoid using gendered terms when you're calling people up. I do know that there's cultural, generational things with that, but like as best you can, please try not to do that. Um, Understand mistakes will happen. When we apologize, just say I'm sorry and learn. Do not apologize excessively because that makes the other person feel like they're the problem for being another. Okay? All right. So some special considerations. We're going to talk about all of these things. So gender diverse people are 3 to 6 times more likely to have a diagnosis or like to identify as neurodivergent or display traits consistent with autism. Neurodivergence is not a medical diagnosis, but it is a way of explaining when someone's thought process and processing and their way the brain works is different than what we have considered normal. And so sometimes people with ADHD are considered neurodivergent. Sometimes it's like people with on the autism spectrum, things like that, and among other things. Okay. This can add further barriers to care. There's a lot of overstimulation that can happen in clinics. There can be challenges sometimes with communication. There's a possibility of learning disabilities, and oftentimes these are overlooked and underdiagnosed. The best way to address this is just as best we can minimize sensory stimuli. It is tough in a PT clinic. I get it. I work in a busy clinic. It's tough. If you have ways to quiet space, that's good. Make strategies to promote exercise completion, but also like if you're working with athletes, sometimes neurodivergence comes out a little differently. It's not like inability to do exercise. It's actually sometimes doing too much exercise to manage some of the like nuances. And so like maybe it's like teaching them ways to like still move and do the things that they need to do to feel better, but not do too much, you know? We need to have an emphasis on when they meet their goals and like saying like, you know, have like this is really good, you know. This is actually a fun like it's not a fun thing. Sorry. It's late. Forgive me. Um Joint hypermobility spectrum disorder and Ehlers-Danlos. So Ehlers-Danlos is a connective tissue disorders, and it's a group of them. There's many different types. And then hypermobility spectrum disorder is describes people whose joints who exhibit symptoms of joint hypermobility without meeting the criteria for EDS. The person I have the picture of is a former patient of mine who has EDS and documented EDS. And like, if his head wasn't in the way, his arm would be like on the other side of the room, to be really honest. Like, that's a way he could like self-dislocate his shoulder. So you commonly see joint hypermobility, musculoskeletal pain, excessive like flexibility in the skin and like things like that. There is actually really fascinating overrepresentation of HSD and EDS in the transgender, gender diverse, and non-binary population. So, in an EDS clinic, and I actually believe this was at Boston Children's Hospital, but don't quote me on that, is in 2022, they found that 70% of their patients identified as transgender and non-binary. The general population rate for identity is 1.3%. So that's a big difference. And then in 2025, a retrospective study at a gender affirming primary care clinic found that 2.7% of their patients had EDS versus 0.02% prevalence in the general pop. So we don't know why there's a higher like there's a higher rate of hypermobility spectrum disorder or Ehlers-Danlos in the transgender and non-binary population, but they are definitely there's definitely been showing signs. And I will say anecdotally and professionally, like I see that every day in my clinic. I know like I was talking to a primary care provider who only treats transgender and non-binary people, and she was saying the same thing. Like she sees it all the time. Like I think a lot of us who treat this population are seeing this as well. We're just not sure why this is the case, but there's definitely like something there. The reason why this is important is they have these comorbidities of chronic pain, fatigue, and things like that, but it can also delay healing and scar healing. So we might need to consider bracing, orthotics, and supportive belts for pain management. All right. Full disclosure, I am not a pelvic floor therapist. So I refer out. Okay. But it's important to know. The pelvic floor is a group of muscles at the base of the spine and pelvis that are integral to the role of core strength, bowel and bladder control, and sexual function. Pelvic floor dysfunction is a really common condition where you can't relax and coordinate your pelvic floor muscles, and it can often come with stress urinary incontinence, urge urinary incontinence, fecal incontinence, pain with intercourse, constipation, pain, pelvic pain, low back pain, urinary retention. There, there's a lot of really good data that shows that pelvic floor dysfunction can occur due to binding and or tucking, which we will be talking about. It's also really common in hypermobile populations. And then hormone replacement therapy. So the masculinizing therapies of testosterone, 94% of people on that had pelvic floor dysfunction, oftentimes finding pain and urinary symptoms the most common. And then feminizing, it was 42%. Oftentimes, there's also behavioral considerations that can cause this. So, bathroom anxiety, being concerned about going to the bathroom for obvious reasons, chronic holding patterns. So, trans men are actually 50% more likely to avoid public restrooms. Okay. And then the disassociation. So, this disassociation will often come due to like our external genitalia not matching and that our gender identity and like having some gender dysphoria around this. And so there's a lack of connection and awareness of our pelvic floor. So this slide is courtesy of Dr. Maddie Urban and Dr. Nora Arnold, who are the coordinator and director of our pelvic floor residency, and they treat all of our trans non-binary patients. This is when to ask about the pelvic floor. It is only relevant to the when it's only relevant to the patient care and their main complaint. We should not be just asking about this region just willy-nilly. It's the same thing as we would do for our cisgender patients, okay? Explain what the pelvic floor is and why you're asking, and ensure that the terminology that you're using is what the patient wants you to use. Do know that it's okay to not do this on the first day. You might need to like figure some stuff out, figure out, okay, maybe this isn't pelvic floor dysfunction, it's just low back pain. Who knows? Let's work this out. That's okay. Build rapport, and it's also okay for the patient to say no. Okay. These questions came from the American Urological Association, and I have the link at the bottom here for the transgender and gender diverse patient care. These are really good questions on how to screen for pelvic floor dysfunction. And these are just some of them. They have some other ones as well. I'm not going to read them because you have them there. Wow, sorry, this is not showing you well. So this is, I'm not gonna read these because I've already been jibber jabbering a while. We have all the feminizing therapies and masculizing. This is not an all-encompassing list. I did not actually include some of the vocal ENT procedures that can be included to change voices and things like that. All right. So, hormone replacement therapy is a primary medical intervention sought by transgender, gender diverse people. The research is sparse and it often is focused on the cisgender population. Side effects are really comparable to hormonal contraception. When you're dealing with adolescents, puberty blockers are used and are very, very effective in the improvement of quality of life. They also can actually help reduce the need for future surgical procedures. So, a lot of times, people who've gone through puberty blockers do not need other procedures because they've actually blocked the secondary sex characteristics that can come in during puberty. So feminizing hormones is estrogen and or androgen blockers. You're going to see the following effects: decreased muscle mass, decreased bone density. You're going to have decreased hemoglobin, and so that will cause a decrease in endurance. Um, you're going to have a change in erectile function as well as a change in sperm count and testicular and prostatic size. You're also going to have a possible increased risk for cardiovascular events, venous thromboembolism, intensity. The intensity of persistent pain and migraine actually does go up, unfortunately. So if you have someone with chronic pain who's starting estrogen therapy, it might be worth making sure they know this. It still is probably going to be worth it for them in a lot of ways, but it's good for them to know. Also, the decrease in bone mineral density is being really, this used to be they used to feel this very strongly, but they're now finding that that might not actually be as true. But it is being found in with the with puberty blockers that you might actually have someone who gets Salter Harris fractures much later in life than you would expect because of the changes in the in growth and everything. And then based off of two studies, one looking at military and one looking at a small group of just like transgender women who were adult and transitioned, both cases transitioned as adults. They're finding that like sports performance took about 2 years to reach with hormone therapy to reach that of cisgender females in strength and endurance, but sprint speed still remained higher. And then masculizing hormone is just testosterone and aromatase inhibitors. So you get a lot of fat distribution, increased muscle mass, changes in hair, voice deepens, you get improvements in strength, endurance, and speed. You have oftentimes there's a sensation of menses. This is not always, and you can always have breakthrough bleeding, breast reduction, vaginal atrophy, clitoral enlargements, increased risk for heart disease and and cholesterol issues, decreased ability to build muscle at the pelvic floor. Um, you might often see, I sometimes see a lot of increased risk of like tendon injuries because of like just going gung-ho at the gym after they started their testosterone. They're going a little too crazy and like maybe get like a overuse injury sometimes. There is some anecdotal, like not great research that like there can be a risk of increased tendon injuries, but it's still poor research at best right now. Um, So padding for feminizing non-surgical gender affirming practice is like trying to enhance hips, buttocks, or chest. There's really no MSK concerns with that, but we are going to talk about tucking. So tucking is the flattening of the genitalia to create a more feminine approach. And so you're pulling the testes into the inguinal canal and taking the penis and scrotums and pulling them back between the legs, or you're taking the penis and testes and pulling them up and back between the legs. And then once you do that, you're using oftentimes like tight underwear, a gaff and or tape to hold the genitalia in place. Okay. There is a great improvement in confidence and sense of self by doing this for every person who does this, okay? But I will say there are side effects. And about half the people who talk report a side effect. Only 8% will receive medical care. And I will say, like, everyone's like, 90% of the information that people get on tucking comes from online forums. It is not coming from medical providers. Okay. Um, and some of the side effects are urethral stress, numbness into the penis, testicular pain, inguinal hernias, testicular torsion, which is actually a medical emergency, low back pain and pelvic floor dysfunction, and skin irritation. The low back pain does come from the anterior tilt that occurs, and I'll talk a little bit more about that. So when we're asking about tucking, we need to ask them about their wear schedule and how they're tucking. So like, are they using just tape directly on the skin if we're dealing with some skin issues? Are we using multiple garments? How tight are we pulling? Are they, and then we need to talk, are they scheduling a bathroom break? Because you can imagine you have to take everything off in order to pee. So they might not be peeing or drinking enough water. Um, you need to talk about wear schedules and address urologic dysfunction. I will say like 99% of the time, you're probably going to refer to a pelvic floor provider in this particular case. It they're better, their skill set is better matched for this. Okay. But again, you're not just asking every person who might tuck if they tuck. We're only asking if it's relevant to like why they're there. And then we need to address their low back pain. So when we're talking about best practices, you want to ease into it. You need to shave the skin to get the hair off. Try to use medical tape over duct tape. It is just safer. And there's a lot less issues with skin breakdown. And then you want to try to tuck for no longer than 4 to 8 hours and try to make sure you're drinking water. But you also need to make sure that the person has a safe place to urinate. And if they don't, you might just need to work with them on strategies of like how to not tuck for super hard to like limit stress of the urethra and penis and testes. When you're talking about some of the orthopedic stuff, you want to correct the anterior pelvic tilt. So what will happen is people will anterior pelvic tilt to further create a flattening of the contour to hide their genitalia and any possible bulge that might be showing. And so you might need to work on some of the things that can happen from prolonged time spent in an anterior pelvic tilt. And then management of any of the pubic symphysis pain. Sometimes what's really helpful is actually an SI belt. Okay. That can be really, really helpful. I promise I'd be under 50 minutes and I'm not going to be, and I'm so sorry. Um, so tucking in sports participation, you just might need to change how the person is tucking. Oh, excuse me. Um, And so I put a website on called Wear Nala, and they have an Everybody Tuck brief. And this was recommended by the community on multiple Reddit forums and multiple sites of trans feminine people who actively participate in tucking. Um, and so you might want to use like compressive underwear rather than tape. Um, and you need to decrease the tension of tucking to limit stress of all the structures, especially if you're participating in cycling or like HIIT workouts or something that requires a great deal of motion or stress to that region. You need to make sure the athlete's monitoring for skin irritation. You need and hydration. We're playing a sport, we're doing a workout class, whatever it may be. We need to talk about, we need to stay hydrated. And then consider ways to make a safe bathroom and or changing space for that athlete. Okay. These are really great resources on tucking and like how to tuck and like they actually folks and Point of Pride and Fenway actually have patient handouts that you can give people. And then masculizing, you have packing, which is use of a prosthetic penis and or other padding to create a contour, masculine contour. Some of them you can actually stand to pee with or use for intercourse, and then binding. So binding is the practice of wearing tight clothes and or garment to create a flatter contour of the chest for a more masculine appearance. Um, so the way that person is standing is you're going to see two ways of standing. Typically, when you see someone who's bound for a long time or for any length of time, you're going to see this, or you're going to see a very rounded shoulder appearance because they're trying to physically hide their chest. Is especially if you have someone that's a little that maybe have a larger chest and it's a little harder to get that flat contour from binding. You might get this like kind of crouched down appearance in order to hide any of the breast tissue. Binding, again, just like tucking, greatly improves the mental health and quality of life and safety of that patient. But 97.2% of people who bind have a negative symptom. And they include back pain, chest pain, shortness of breath, overheating, shoulder pain, numbness, tingling, rib pain and dysfunction. The rib fractures were two patients, and they're not convinced, but they had to include it in the study because they were part of the study, but they are not entirely sure it was from binding. So material matters. Please, 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 please avoid duct tape. It was not uncommon, especially when I was younger, to know people that would like literally duct tape their entire chest like in a tourniquet fashion. And you can imagine, we're all therapists here, why that would be bad. Ace bandages are also not good, but if you have someone who is really in a financial position where they cannot access binders, I would rather them ace bandage than duct tape because of the safety of the skin, and like you can get severe blistering of the skin. But the thing with ace bandages and duct tape is you also get like the skin will like can pucker and literally blister. You get uneven compression, so you can cause a lot of rib issues and things like that. You do need to measure for the proper fit. I'm going to be really honest with you. There is probably less than 1% of trans people who bind that wear the right size binder. I'm just telling you that. I'm telling you that as a person with a with a medical degree who was that person, okay? It you want it small because you feel better, even though it's not probably making it look better. It just is, okay? You should really only be wearing this for 8 to 12 hours. Again, I am the first person to admit I've worn one for 20 and it's not great. Okay. You need to schedule an off day. Again, that's not something that's going to happen for some people. And you also need to not double bind. So double bind is wearing two binders at once. Most trans people who bind have done this, myself included. It's not recommended. For the safety of the back and the shoulders and everything, and breathing, just breathing. So again, you want to know their binding schedule, how they're binding. You need to educate them on not sleeping in it. This is just to give them a break. The thing is though, is a lot of people will want to sleep in it. So if they need to sleep in it for their own mental health, then do consider like trying to educate maybe on different types of compression, maybe compression shirts, maybe a sports bra, maybe a bigger binder. So they're getting a little freedom during the day. And then you need to address these musculoskeletal impairments, which we're going to talk about. So, um, when you're taking it off for sport or sleep, so again, for sport, it's the same thing, like looser, less restrictive, things like that. But your patients will say no, and it's okay. Um, when they say no, I try to teach them tools how to like work around some of the problems that occur with it. The thing is with the binder though too is it actually will restrict your shoulder range of motion. So if you do have someone that has to do like let's say they're a CrossFit athlete and they're binding and trying to do like a snatch, overhead press, a butterfly, a muscle up, like there could be some other things that occur because of the restricted range of motion that happens with binders. So breathing mechanics, I think we all know the basics of breathing mechanics. These get altered by wearing a binder. And so it's really important that we address the range of motion in thoracic spine and rib cage. The thing is like a lot of times when we're talking about breathing, most of us only focus on the diaphragm, do focus on the diaphragm. It is important, but you really need to work on actually is this upper chest breathing for rib expansion because this is where the binding is happening, is in that upper chest. So you need to like actually get them to open up that upper chest. So it's like almost a little backwards than what we normally do with the diaphragmatic breathing. We're actually trying to focus a little bit on this like upper rib cage expansion, but also the lateral costal expansion. So you, if appropriate, you might need to do manual therapy, maybe like some facilitation with like trying to get them to like either with their hands and like use and like open up that space. Okay. Um, when we're talking about the shoulder pain or back pain, we need, again, it's mobility. A lot of times, because of the way the binders are, they pull you forward into this bent position. So you get that lengthening of the back muscles and the weakness that comes with it and the really excessive tightness in the pec area. Okay. And so you're going to have problems with that. And so you need to address those. Um, these are just pictures of like ways to stretch. I'm gonna be honest. A lot of people are gonna want to wear the binder through that. That's fine. I would rather them do the stretches in a binder than not do the stretches at all. Okay. All right. Wear a loose fitting binder. Try to consider the range of motion, things that happen when you're playing sports, but also think about the breathing. My big thing is actually heat. Um, Heat related illness is a very, very serious thing and can get very bad fast. And so you want to make sure that the person, if you know you have an athlete that's binding, that you're monitoring them for heat related illness. Okay. You also need to watch the skin. You want to make sure you include breathing and thoracic mobility in their warm up. These are resources. There's Point of Pride actually has resources on free binders as well, which can be life saving for so many people. I just want to make that really clear. Um, all right, I'm gonna do a really quick plug. If no one is upset about this. So Johns Hopkins is we're hosting our role of rehab in the caring for transgender and gender expansive adults conference again on March 21st. It's online and it's $65. It's from 8 to 1 Eastern Standard Time. This is a really, it's not just me jibber jabbering. I have the head of the Transgender Health Center who does all the like most of the surgeries for the center is presenting on surgical stuff. I have Maddie Urban who is going to be presenting on the pelvic floor, Amanda Green who presents on hypermobility, Ashley Davis who is a speech therapist who actually talks about how to address speech and voice for trans people, Rachel Pigot, who is our OT who deals with phalloplasty care for the forearm grafting and post mastectomies. And I'm forgetting someone. Oh my God. And me, I talk a little bit too, but you've just heard my presentation essentially. But yeah, so it's actually a really wonderful conference that like includes multiple practitioners who actually have a different have extensive experiences working with this population in different ways, and they bring a lot to the table. So the link is actually now open. So if anyone's interested, and then these are some resources. And it's also there are resources and references, to be honest. They're really, really wonderful. Yeah, so thank you again so much for your time. I really appreciate it. I don't know if there's any questions.
Real quick, before we get into questions, Keelan, if you don't mind, just that link that you did share, if you could, are you able to copy and paste it into the
Okay,
chat for everybody?
I am.
Perfect. And then otherwise, yeah, let's go ahead and if people have time, let's take advantage and share any questions that you have for Keelan. That was fantastic. And if there's no questions, I'm still going to let people think about that. I am going to share some information for PT Proud. If you aren't a member, want to read up on that, I'll share that in the chat. And I believe the sports committee is also going to share some information as well. So if you want to inquire about either, we want to give you the opportunity to do so.
I'll just put I can be the point of contact for the Rise Committee. Anyone would like to get more involved or has any questions? Keelan, I think you did too thorough of a job, and that's why we're not seeing any questions.
All right.
Because this was amazing. So we really,
Thank
really
you.
appreciate your time and your expertise and your willingness to share some of your personal story as well.
Thank you. Thank you for everyone coming. It's really great.